With breakthroughs come questions. Have we solved the issues? What do we do with this therapy that's now not the first therapy? How do we combine them? What does BRAF mean? I just had a patient who's been my patient for a couple of years. Say, we were talking and he said he's doing well. He said, what about BRAF? Do I have the BRAF mutation? And I think we've talked about that initially. It was part of 100 different conversations, and then it sort of fell back to the wayside. And really, there's been a lot of change in how we deal with targeted agents in melanoma. When I have questions about targeted agents in melanoma, I go to some of the slides I've stolen from Dr. Sullivan over the years. The answers invariably are in those. I won't give him the satisfaction of a call, but the answers are there. And, we've talked about lineage and who trained what and who did. Dr. Ferries has been trained by Don Morton, who was the dean of surgeons, and Dr. Ganji has come from Moffitt, where the surgeons reign supreme over the medical oncologists. And it's true that Dr. Sullivan has learned from one of the leaders in targeted therapy and has taken all of that and just moved it another level higher. So I'm sure you will enjoy the talk. It's always a intelligent, entertaining discussion, as per the discussion last night. So please come on up, Ryan Sullivan.
Well, thank you so much. That was a very kind introduction. I hope I can live up to it. I'll do my best. Boy, it's been a long-term time since I've been up at a lecture and I can't figure out which way to go. Okay, good. So this is my task, is to talk about BRAF targeted therapy and other targeted agents, and thinking about today and also thinking about tomorrow. It's important to start with disclosures. And so these are some of my disclosures. I have one additional disclosure, which is we're living in an immunotherapy world, and I am an immunotherapy girl. I'm relatively certain Madonna never said that. Now, because immunotherapy is so dominant, one might wonder what I'm doing here. And in fact, Dr. Carvajal last night indeed asked me, what are you doing here? You're welcome. And seriously, I think a question that comes up when you hear about these fabulous immunotherapies and truly the power to make someone's immune system better fight their cancer is the goal we should be building towards. It's the best chance that patients can have for durable benefit and our ultimate goal, which is cure. And so it's reasonable to ask questions like, okay, there's these other therapies. Is there any role for these after what we've heard from Dr. Carvajal and Dr. Ferries? And the answer is, I think there's a quick reminder here, or a few quick reminders. One is that there actually were two fundamental discoveries made in the last 30 years that have led to improved outcomes for our patients. The first, which is on my right, your left, is all of the stuff that people have talked about, immunotherapy. We've learned how the immune system interacts with cancer and how cancer interacts with the immune system. And we've developed and generated highly effective drugs for many patients, not every patient, unfortunately, but for many patients. But the other thing we've learned, and that's on the right of this screen, is that cancer, generally, melanoma specifically, is a disease of abnormal genes. And sometimes those abnormal genes activate, and those activations can lead to improvements for the cancer cells in survival, in growth, and spread and evading the immune system. And if only we could target these mutations, we might be able to treat people better. And so this pathway, which is depicted on the right and on the left, what I've done is I've shaded the patients who have what's called a BRAF mutation in red. I've shaded about the quarter of patients who have an NRAS or KRAS mutation in green. And I've shaded the about 10 or 15% of patients that have something called an NF1 mutation. And then over here, here's RAS. So this is like cancer signaling, actually general cell signaling 101 or maybe like 302. But ultimately, there's signals that that kind of come from the outside world and interact with cell surface molecules that then activate stuff. And this is what can activate is this pathway that's also called the RAS, RAF, MEK, ERK pathway or MAP kinase pathway. And in red are mutations in genes that we sometimes see in melanoma. So BRAF, NRAS, c-KIT, GNAQ, GNA11. You'll hear more about those later. There are other pathways that kind of can be parallel to this and interact. And we've now developed drugs that can block these proteins relatively well. And so for the remainder of the talk, I'll be discussing what we do when we block these proteins and how the blocking of those proteins may be optimally used for patients with BRAF mutated melanoma or some of these other mutations. And so in addition to the sort of things we've learned, so we have multiple adjuvant, I guess I even put multiple adjuvants in that sentence, which is interesting. So we have multiple adjuvant therapies for patients with stage 3 melanoma. So we heard about the Checkmate 238 study and the Keynote 054 study from Dr. Carvajal earlier. We didn't hear about this trial called the COMBI-AD, but what adjuvant therapy, which is described, is treatment that's given after surgery. So curative intent surgery, but there's a risk that the cancer will come back, and we give treatment to try and reduce that risk. So we have three options, and these three options, two of them are basically the same. Sorry to anybody who works for BMS or Merck, but these are drugs that essentially work the same. They're PD-1 blocking drugs. They look very similar. Dabrafenib and trametinib are two different drugs. These are BRAF and MEK inhibitors that are targeting that pathway that I showed earlier. The other thing that we also are going to talk about is there are many unmet needs in advanced melanoma, and these include what the heck do we do for patients when we've used up all of our immunotherapies and patients still have melanoma? Like, how do we treat those patients? How can we help those patients? We might be able to think up and dream up more immunotherapy combinations or give tumor infiltrating lymphocyte therapy for patients. But ultimately, if that patient has a BRAF mutation, we're also going to be thinking about how to block that pathway. And if they have other mutations, we may also be thinking about how to block that pathway. So one of the things that I'm not sure Dr. Hamid steals these slides because he always makes fun of my stick figure patients. But this is my stick figure patient. I know that patients are real and they're three-dimensional, and I care very deeply for my patients. But for purposes of talk, I make them stick figures, so I apologize. So this is just a patient who has a BRAF mutation. They have completed their surgery, and they're sitting in front of myself or another medical oncologist, and we have a dilemma that we have to solve. What do we best recommend to this patient? Do I offer this patient BRAF targeted therapy? Do I offer that patient immune targeted therapy? And I'm going to briefly go through this, but ultimately in blue is BRAF MEK combination, and red is double placebo, and this is relapse rates. And so if you're still on the curve, you haven't relapsed, and you can see that blue, there's more people who haven't relapsed than red, and this is with 5 years of follow-up. there's a lot of words on the slide. It works. It's FDA approved. It's an effective therapy. This is a summary in a different way that Dr. Carvajal showed of the two studies of the PD-1 blocking drugs. This is the Keynote 054, so that's pembrolizumab. This is the Checkmate 238, that's nivolumab. Again, the blue curves are higher than the red curves. That means you're less likely to relapse if you get the drug pembro or nivo than you are if you get the other stuff, which here it's placebo and here it's ipilimumab. So again, a lot of words. These drugs work. And in fact, when you do this thing that statisticians vomit over, but we do all the time, which is to cross-trial compare, it looks about the same. The 4-year relapse-free rates are about the same. The prevention of distant metastases is about the same. These are just different ways of doing it. This is a hazard ratio, but these hazard ratios are close enough, and this is comparing against an active comparator. So it's probably, if you kind of back of the envelope calculate, it's about the same. So I would just say that this slide, lots of numbers, but these drugs are basically the same in terms of how effective they are. So then what's the difference? Well, they have different side effects. BRAF targeted therapy is actually fairly toxic. About 60-70% of patients will have a severe side effect at some point during the course of their treatment. These other drugs, ipilimumab is way more toxic than placebo. It's more toxic than PD-1 blocking drugs. Pembro is a little bit more toxic than PD-1 blocking drugs. So you can look at severity and frequency, but you can also look at permanence. And I think what's important to note here is that there are permanent toxicities that happen with our immunotherapies that just don't happen with our BRAF targeted therapies. BRAF inhibitors work like every drug, or almost every drug, because I'm going to tell you drugs that they don't work like. You take the drug, a level in your body gets in there, your body clears the drug. If you're having a symptom or a side effect from the drug, it's there when you're at the peak dose of it, and when it clears out of your system, it goes away. So BRAF targeted therapy works basically like every other drug. Immune therapy does something very different. Now, it's the reason it's so exciting is that it can change your immune system so that you now have immune elements that are attacking yourself. And that may persist unless you actively reverse it. And so that's a distinguishing feature between these two types of therapies. And just more on chronicity, we call these side effects of immunotherapy immune-related adverse events. It's basically just immunotherapy side effects. And what we've shown in a large group of, I think I guess it's on there, 8 academic centers in the US and Australia, that about a quarter of patients have severe side effects, or about 20% rather. And of those, about 40+% have persistent side effects. So that we define persistence as you stop, and 3 months later, you still have side effects. And the most common side effects are like thyroid inflammation and joint inflammation or achiness. But we see other stuff too. We see skin side effects. We see colon side effects. We see eye side effects and nerve side effects and lung side effects. So we can see permanent side effects with these types of drugs. And so kind of putting it all together when I'm in front of my 3-dimensional real patient, but for the purposes of this, the stick figure patient, BRAF targeted therapy actually probably works better when you have less disease. Also, like other types of treatment in cancer, when you can't see it, there's less tumor, you actually don't need to kill as many cells. These drugs can probably kill many of the cells that are still there and help prevent it from coming back. BRAF and anti-PD-1 therapy are similar in how well they work in the adjuvant setting. And I think that another important point about PD-1 blocking drugs is the immune system may actually be interesting in that in the setting of these drugs, it may not actually matter how much tumor you have. If you have a lot of tumor, it probably matters. But if you have a little bit of tumor that you can't see on a scan or a little bit of tumor that you can see on a scan, I'm not convinced that these drugs work any better in the person who has a scan that doesn't show any and just had surgery, or a patient who has a relatively small amount of tumor on a scan, because the immune system sort of works very similarly in that setting. It's hard to imagine it's going to be dramatically different. And the last point is that there's more severe side effects with the BRAF targeted therapy, but there's more chronic side effects with the immunotherapy. And so, what do I do when I'm faced with this? My bias, although these are long conversations that I have with patients, and we go through all of these features, but my bias is to give the BRAF MET combo because it's potentially curative at a similar level as the PD-1 blocking drugs at that time. There are reversible side effects, and salvage, which is essentially, can we cure somebody later? Salvage immunotherapy seems to be effective in this patient population for some patients, but at a rate that we might expect that they would have long-term control if they didn't receive this treatment. So that's one potential way we can use BRAF targeted therapy in this era. Back to here, I think one important thing to say in the metastatic setting after immunotherapy has stopped working, I'll get to that one important thing to say, but here's my version of the slide you've seen. In red are the BRAF targeted therapies, and in the sort of darker blue or black are the immune therapies. Lots of progress. But now we have this patient with advanced BRAF mutant melanoma. And Dr. Carvajal showed this already, but I think it's important to know it's not either or. We're just going to give patients probably both at some point in their case. The frontline data with BRAF targeted therapy demonstrates that it works, but this last one is the study that Dr. Carvajal showed, that essentially patients who start with immunotherapy, in this case, ipilimumab, nivolumab combination, ultimately do better than patients who start with BRAF and MEK inhibitor therapy. But we have limited data about how well these drugs work after immunotherapy. With that said, I think there is a role for every patient who has metastatic BRAF mutant melanoma, with rare cases excluded, who are not cured or do not have long-term benefit from immunotherapy to receive this. Said another way, I don't think a patient should probably go on hospice if they have a BRAF mutation, if they haven't received BRAF targeted therapy. We can improve their life, we can extend their life in that scenario. Here's the only significant data we have in a prospective study about how well BRAF targeted therapy works in the frontline setting. So Dr. Carvajal showed you this, and in the second line setting. So essentially a very similar response rate. 5 minutes, thank you. We don't know for how long this worked for those patients, but we think it's similarly effective in both of those settings. And so we think that this is something that a patient with BRAF mutant melanoma after immunotherapy, if they haven't gone into remission, should be considered for. Now, it is sort of becoming an existential question, which is, can we make BRAF targeted therapy better? Is there anything we can do to modify this complicated mess to try and make the BRAF inhibitors better? And so, again, lots of boxes and ovals and things like that, but ultimately, every darkish thing here is potentially targetable with drugs. And the one thing I'm going to talk very briefly about, and so I've started, all of these things are potential targets that if we could safely give those drugs that target those things with BRAF targeted therapy, we'd probably make it better. It's a little bit more complex though, because if you start adding a bunch of these drugs, you start increasing the side effects. But one thing I'm going to talk about very briefly is this concept of apoptosis and targeting it. Apoptosis is otherwise known as programmed cell death. It is a way that cells can die. It's a way that cancer cells can be killed. And it's also a target because cancer cells are actually really good at preventing this from happening. And so there's a drug that's actually used, or a drug actually, second generation of that drug is used in some certain types of leukemias, lymphomas, that blocks a key mediator it blocks a key blocker of apoptosis. Navitoclax is sort of like that. And so we added navitoclax to dabrafenib and trametinib. We did a phase 1 study, fairly complex. We had a lot of bunch of dose levels. And the point of the phase 1 study was to find a dose. And in red, this is the dose we found. Importantly, the D, which is dabrafenib, and the T, which is trametinib, this is the same dose that we give to patients if we were just going to prescribe it to a BRAF mutated patient. So we didn't have to lower the dose of the drug that we know, or the drugs that we know are effective in this patient population. And we added this drug navitoclax at a dose that's a little bit lower than the maximum tolerated dose, but we felt pretty comfortable with this result. I'm not going to try and read that for sure. The second part of this study was actually a randomized trial. And we randomized patients to receive 3 drugs or 2 drugs. We just finished accrual about 2 months ago, and we'll probably do the analysis of the comparison in about 2 or 3 months. If this is a positive study, it'll be really exciting, and it may help to open up a new avenue in terms of how to treat patients. Importantly, most of these patients, even though you didn't have to, but most of these patients receive prior immunotherapy, right? So when we initially launched this, which I'm embarrassed to admit was in 2013, we didn't have PD-1 blockers that were FDA approved. So a lot of patients actually could have conceivably gotten this as their first therapy. It's not something that we've been doing in the last several years. So this will actually be appropriate. The data we get will be appropriate for this era. What about BRAF MEK inhibitor resistant patients? What about NRAS mutant patients? What about NF1 mutant patients? Well, I'm going to flip off of this screen very quickly, and then you're going to have to remember everything, and there's a test. But this is actually a figure from a paper that we've just published, and Poulikakos is a leader in bench research about this pathway. And he and one of his postdocs came up with this figure. But ultimately, what it shows is there are a lot of targets for cancer cells that activate this pathway. And importantly, what we're doing with this information is we're using things that target. So we're targeting ERK. We're targeting RAF in a different way. We can target MEK. We can target RAF in a different way and MEK. And what we're seeing in these, you've seen waterfall plots now. These are patients who are very resistant to treatment. And a lot of these patients are having benefit. And so we're starting to see some evidence of activity. And what we're hopeful that we'll see over the next few months, next few years, is that these combinations begin to get into larger patient populations, and that ultimately we might be able to translate some of these into FDA-approved regimens. This is the combination that actually showed pretty nice effects. And what this has done, even though it does not that many patients, and it's like only half of patients did well, but what it's done is it's led to a number of new combinations that are making their way into the clinic with different drugs that are slightly different in terms of how toxic they are, how tolerable they are, what they're targeting. And I think at least 1 or 2 of these will turn out to be quite effective for our patients. So to conclude, I think first of all, there's a role for targeted therapy early in the adjuvant setting and late in patients with metastatic disease after immunotherapy for patients with BRAF mutant melanoma. So despite the fact that we are living in an immunotherapy world, there is still a place for targeted therapy. And there are new targeted therapy strategies that are emerging to treat BRAF, NRAS, and other oncogene populations or driven populations. And hopefully over the coming months and years, we'll have more data to share on that. So with that, I thank you, and I look forward to the question and answers later.